already. So good afternoon, everyone, and welcome to the BHF Data Science Centre's monthly webinar. And many thanks to all of you for making the time to attend. My name is Reuven Preden. I'm one of the Centre's BHF Data Science Centre's research project managers, with a focus on managing the CVD-COVID-UK COVID Impact Research Programme within our structured data thematic area. And I'll be chairing today's webinar. Today, we're delighted to welcome Dr. Hoda Abbasizanjani and Fatemeh Torabi from the Population Data Science team at Swansea University. Hoda and Fatemeh's presentation is entitled Harmonising Electronic Health Records for Reproducible Research, Challenges, Solutions and Recommendations from a UK-wide COVID-19 research collaboration. The related paper was published in BMC Medical Informatics and Decision Making in January this year, and we'll post a link in the chat for those interested in reading it. Before I hand over to Hoda and Fatemeh, may I please ask everyone to kindly keep their camera and microphone switched off, and to make you aware that this webinar is being recorded, and it will be made available along with recordings from our previous webinars on the BHF Data Science Centre's playlist on the HDR UK YouTube channel. There'll be time at the end of today's talk for discussion, so please post your questions in the chat and we'll do our best to answer as many of the questions as time allows. And finally, if you would like to present at a future webinar, do let us know in the chat, and Kate McAllister, our communications manager, will follow up with you. So without any further ado, I'll now hand over to Hoda and Fatemeh.
Thanks, Reuven. Thanks for the introduction. I just need to share my screen. Okay, can you see? Perfect. Hi, everyone. I'm Hoda Abbasizanjani, and as Reuven mentioned, I work in population data science at Swansea University. And I work for the ADR Wells team now, and previously I worked with HDR UK and BHF Data Science Centre and CVD-COVID-UK consortium. So Fatemeh and I will be presenting an overview of the work on a reproducible data harmonization process, which was done as part of the CVD-COVID-UK consortium to enable efficient collaboration between UK's trusted research environment, and we will also discuss some main challenges for data harmonization between TREs. So as you know, using multi-nation studies provides larger sample size, which improves statistical power, especially for rare events. And it also provides us the opportunity to see if we can generalize results from one population to other population and nations. So the CVD-COVID-UK consortium was funded by the HDR UK to investigate relationship between COVID-19 and cardiovascular disease through analysis of health data. So far, through the consortium, individual level data from 2 UK nations has been accessed on more than 65 million individuals through these 3 trusted research environments. So we have SAIL Databank in Wales, NHS-D TRE in England, and National Data Safe Haven in Scotland. So this already provided a really great opportunity for research and analysis within these TREs and across these TREs. And I know that further work is ongoing to enable access to Northern Ireland data. So how can we enable efficient collaborative research between TREs, 2 TREs, or in general, any 2 sources? Here we see a simple example. So we have some similar variables from 2 sources. They have same name, but does that mean that we can use them as they are? As you see in this example, similar variables from 2 sources could be coded differently. They might have different categorization, different ranges, or they might be measured or recorded in different units, or they might have different format or data type, or even similar variable could be derived from similar data sources, but with different coverage. So in general, administrative and healthcare data from different sources could have so many differences because the underlying healthcare system could be different. Also, the types of data collected, the coding system, and other information could be different. So we need data harmonization in order to make data and statistics more comparable, consistent, and coherent. Over the past 2 years, we have been involved in a wide range of projects, CVD-COVID-UK projects, and there has been more than 10 projects which we use Wells data within SAIL Databank in collaboration with other TREs. So here you see some of these projects. Some of them are completed, some of them are still ongoing. So in order to support and facilitate all these projects, we needed to implement a harmonization method which was also reproducible and scalable, because some of the initial data cleaning process for these projects are similar. Many phenotypes and variables derived for these projects could be reusable for other studies. And we also wanted to have a list of variables, like a shopping list, so that we can use for future projects to enable them to start more quickly. Over all these projects, so for them, so far we have harmonized more than 100 demographic and health-related variables, and these can be grouped into these categories. We have had demographic variables such as age, gender, date of birth, date of death, and so on. We have ethnicity, we have some variables related to socioeconomic and geographical characteristics such as deprivation and LSOA. We have some biomarkers such as BMI, blood pressure. We have some lifestyle risk factors such as smoking status, alcohol consumption, some comorbidity indexes such as Charlson or Elihauser comorbidity indexes. And we have harmonized so many variables and phenotypes related to medication and disease phenotypes, as well as some hospital interventions and procedures such as different type of ventilation or ICU admissions. So how did we implement the harmonization method? This figure shows a very simplified version of the harmonization method we implemented in SAIL. So the top layer has raw data sources in SAIL. In layer 2, we have curated data. Then in layer 3, we have generated phenotype data tables using data in layer 2. And finally, in last layer, we generated project-specific data, which are fully harmonized between projects in the involved TREs. Before I go into the technical details of layer 2 to 4, I'm going to discuss main challenges for data harmonization between TREs. And my main focus would be SAIL Databank and NHS Digital TRE. So one of main challenges for data harmonization between TREs is to have a reliable population denominator with a set of consistent demographic characteristics such as gender, date of birth, date of death, and so on. But trying to achieve this in all the involved TREs could be challenging, because in some TREs we can access some data sources such as ONS census, which provide a snapshot of the whole population. But in some other TREs, we might not have access to such data, and instead, population denominator could only be defined based on individual who have had an interaction with healthcare system or registered with primary care system, primary care. So in addition to this, also the longitudinal nature of health data leads to accumulation of individuals. So as a result, in health data, the number of individuals tend to exceed the general population. Therefore, it's best to use multiple data sources if available to define a population denominator, especially birth data or mortality register. And I think the gold standard is to have a population spine, which every person can be identified uniquely in the population spine. And once a person is added to the cohort, they shouldn't be removed. Instead, their status change following, for example, mortality or migration. And therefore, population spines should be updated in a regular basis to capture any change in the population. Another fundamental challenge is to have consistent derivation and definition of analysis variables. So achieving this in all TREs could be challenging, because similar data sources in different TREs might have different coding system or clinical terminologies. For example, primary care data in SAIL is coded in READ, but in NHS Digital TRE, primary care data is coded in SNOMED. Also, if a coding system has been retired or a different version of a coding system has been used historically, this could add additional challenges. And Also, laboratory result or some other data sources from different TREs might use different reporting units, calculated parameters, formats, and so on. So all of these could pose additional challenges for data harmonization between TREs. Therefore, phenotypes need to be established in a unified manner. There should be a process for expert review and validation of mapping between coding system, and then these unified phenotypes could be used to derive harmonized variables. Another challenge could be regarding transparency and communication. So within a project, not all individuals have access to all the involved TREs. Therefore, it's important to establish clear communication and transparent documentation to validate the approach within each TRE. Other challenges could be regarding different IT infrastructure in involved TREs. Different data storage platform or statistical analysis software means that the format of code used for data extraction or analysis could be different in TREs, and therefore we cannot always copy and paste code between TREs, and in some cases different programming expertise might be needed. And depending on the size of data in TREs, we might also need to use distributed computing, and if the performance hardware is limited in some TREs, this might be an issue. And given transparency and communication challenge, it's really important to use some sort of version control system, for example, Git, GitLab, or GitHub. But if some TREs doesn't have access to this kind of version control system, this might be an issue. Finally, for combining and meta-analyzing the result from TREs, we might have some challenges because of the differences in the disclosure control process in each TRE. So it's important that researchers be aware of these differences for the disclosure control processes. For example, when using some data such as ONS census, small numbers between 0 and 10 are not allowed to be released from the TREs. So going back to the harmonization method. So as I say, in the first layer, we have raw data sources in SAIL. Then in second layer, we have two types of data. One is research-ready data asset, or RRDAs in short. These are generated from one or more data sources by applying some quality check, linkages, and pre-processing procedure. An example of RRDAs is a population spine for COVID-related researchers. So this cohort has all the individuals in SAIL, all individuals who are alive and living in Wales on 1st January 2020 with follow-up through multiple data sources until end of 2022. And it's the detail of this cohort and another cohort is explained in a paper by Jane Lyons. We have a harmonized ethnicity spine for the whole population of Wales. It is derived from, I think, 26 data sources across 22 years, and it's also explained in a paper by Ashley Akbari and others. Another example is the RRD version of dispensing data, which Fatemeh has developed, and she's gonna explain about that in more details. In addition to RRDAs, we have generated curated version of other raw data sources by applying some initial data cleaning and linkage to population spines. Examples are curated version of primary and secondary care data sources or curated version of COVID-19 testing results. In layer 3, we have generated phenotype data tables. So each table has all records related to one phenotype or a group of phenotype within a table in layer 2. An example is a table which has all the COVID cases in primary care data generated from the curated version of primary care, or another table, we have all the records related to a group of CVD in primary care. Finally, in layer 4, we derive fully harmonized data. So it means that all the table names, variables name, their range, and their value are harmonized, are same between TREs. Therefore, any analytical pipeline developed in one TRE could be applied to other TRE with minimal changes. So this slide shows a full picture of the harmonization method used in one of the projects that we use SAIL data. So I won't go into the details. I just wanted to show you the complexity of the process. In this slide, we see the process for meta and pool analysis between SAIL and NHS-D TRE brain glands. So as I said, data remain at each TRE, they're harmonized, and then same analytical pipeline can be applied to the data, and then only aggregated results are requested out of the TREs through the disclosure control, and then they can be combined using meta-analysis techniques. For all the projects that we have done, all the scripts are available in GitLab in SAIL. And for the ones that we complete, we make all the script available through the BHF Data Science GitHub repository. And my final slide, so we see some of the outputs that we have had so far. As Ruben mentioned, we had a paper about the harmonization method, and the others are related to some other project that we did between SAIL and other TREs. And I think Fatemeh is going to talk about one of these projects in more detail. So that's all from me. Thank you, and I hand over to Fatemeh.
Great. I think you should see my slides now. Thank you very much, Hoda, for the wonderful insights into harmonization process. As you saw, the harmonization journey started from the raw data. So the first layer that Hoda demonstrated brings the raw data sources together and carries over into a single TRE harmonization approach. Once we achieve the single TRE for harmonization, what came through this collaborative effort was development and implementation of protocols across multiple TREs. We built enriched data assets that empower timely investigation of health data across different nations. So the resources we built in this collaborative effort, which many have contributed to, was the result of multi-TRE network across the UK. We are focusing here majorly on the research and analytical side of this journey. I would also like to pay a tribute to collaborative effort on achieving safe access to patient data through appropriate governance and infrastructure. It wouldn't happen without having the consortium such as CVD in place. So an example of the analytical and data curation, as Hoda briefly covered, was our work on TRE level research-ready data assets for the Wales dispensing data available in SAIL Databank. Same as the majority of healthcare data recorded as electronic health records, the dispensing data is also a byproduct of the healthcare system, which means that the routine community dispensing patterns get expressed within the data in various ways. This is why extracting knowledge from the raw version of all these data sets, including the dispensing, is really hard. And in the context of drugs, the complexity of EHR can be compared with the well-controlled environment of clinical trial studies, where recruiting a population within a clinical trial means that the researcher can control and design many of the data-related factors from initiation. Well, we all know that this level of control is not there in EHR, and specifically in the routinely collected data, but it is possible to get closer to the nature through one of the solutions which we proposed as harmonization. So what we did in the dispensing experience, we curated the dispensing data set through a semi-supervised pipeline. The Welsh dispensing data set comes with one row per dispense item. So each person, for all of their dispense items, they have a row assigned to them. And the initial data source is coded in DMND, which is a subset of SNOMED codes. And because it captures also the package and number of items, there are some duplication records when we want to look at the only BNF level data. So our curation pipeline preserved this data, linked it to the demographic information. We also mapped the DMND codes to BNF that was mainly to enable further collaborations, because the BNF coding is what is used in most of the TREs and across the drug investigation projects. So another layer of complexity, which Hoda also mentioned, was the scale of this data, which we needed to account for specific consideration to optimize the use of databases and analytical resources within the TRE. Let's look at more detail on how achieving harmonized resources in the TRE contributes to our collaborative effort on drug dispensing data. So moving on to the implementation of research protocols, the major data sets, Hoda already covered those, so I won't go into duplicated details, but the Welsh dispensing data set, the research-ready version of this data was linked to two population spines, which are the ones that I annotated as C20 and C16. These are the data set that provides a current population spine capturing characteristics such as birth, death, deprivation score, and migration for the entire population of Wales from 2020 onwards, which was the relevant start date in the context of COVID-19 analysis. Jane Lyons and her team also created a similar counterfactual cohort starting from 2016 to enable monitoring of historic and pre-COVID patterns across the population. Another data asset that we used was the ethnicity spine developed by Ashley Barry, which had readily accessible ethnicity records for the entire population of Wales, and these records were compiled from 26 linked data assets on the raw level and made these readily available to the project. The harmonization work led by Hoda provided us with readily available cohorts defined based on the protocols developed in collaboration with CVD-COVID-UK consortium, and also capturing the common outcomes and covariates involved. Indeed, we needed the flexibility to allow us to develop the new conditions or disease indications into the pipeline, and that's where the GP and hospital data comes into this cohort creation journey, which I put on the side. So this enabled us to monitor for study-specific disease indication and outcomes, which then got incorporated back into the harmonization process. So these resources majorly contributed to Wales' preparedness for multi-TRE analysis. An example of this is the work that led by Prof. Richa Sofat's team, specifically the three-nation investigation led by Caroline Dale and her team on the impact of COVID-19 pandemic on cardiovascular disease prevention and management. To give you an idea of the scale of data involved in this analysis, across the three nations of the UK, 1.32 billion dispensing records have been analyzed. So for this work, we used the drug dispensing, the research-ready data asset that was already available in Wales within the protocols developed for CVD-COVID, and the drug dispensing was used as a proxy measure for how CVD conditions get managed by focusing on antihypertensive, insulin, lipid lowering, and type 2 diabetes drugs. And the work showed a marked decline in insulin dispensing for all these medications in the immediate post-pandemic period. So in the three-nation dispensing work, Caroline and Rohan were the ones orchestrating all these efforts, and in a lot of those collaborations, the lead contributors had to orchestrate these efforts. So coming back to the challenges that Hoda covered, where are we at the moment is all these solutions for harmonization to achieve efficiency in implementation of research protocols across multiple TREs are developed at the moment in the TRE space. So to preserve the learnings and practices from this harmonization work, the knowledge share across multiple TRE networks is highly important. In all of these experiences outlined, each analytical pipeline have been developed in R, Python, SQL, or other analytical software within a single TRE using harmonized phenotype lists, and then the results were pulled or aggregated together after passing required disclosure control checks at the TRE level. So as a concluding note, I would like to propose to this community and all of you the ambitious goal of achieving patient-level multi-TRE analysis in a single safe environment. I'm aware of how ambitious this proposal are, and I would like to hear your thoughts about this, and if I can answer any question, happy to do that. If you too are interested in this, please feel free to get in touch or tag us in. This all would not have happened without our funders, and indeed the great support from CVD-COVID Consortium and the One Wales collaboration. Those people who I named are a part of the big contributors who have directly contributed to the pieces that we presented today. So thank you to you all, and that's me ready to take some questions. Thank you.
Oh, many thanks, Hoda and Fatemeh, for outlining all of your fabulous work that's been going on over the last few years, in fact. So we're happy now to take questions. There seems to be lots of thought going on about the questions at the moment, but feel free to post any in the chat or put your hand up and we can take questions from you directly. So whilst those come in, I've received a few questions in the background. So firstly, Fatemeh, a question for you. So can you explain a bit more on how real-time monitoring of dispensing data was achieved while the data was within a trusted research environment?
Oh, thank you, Ruben. That's a very thoughtful question. As I mentioned in the last slide, what we developed and produce at the moment is within the trusted research environment. So to achieve, we published a live dashboard with the dispensing work, and to keep it live, we needed some kind of connection to the actual data. So we were receiving monthly updates of the dispensing data set that was run against the pipeline that we developed. And what we had to do is to also create an aggregated data set that was safe to extract from the TRE through the disclosure control, and that would come through each run and be directly fed into the live dashboard to keep it going. So that's to preserve the safety of patient level data within the TRE, and that was our solution. But if you have any other more optimized, better solution, I'm open to hear and very interested in that.
So we've had a few questions and points coming in now. So firstly, from Anthony Lightiness. He says, were there issues regarding data quality, so completeness, consistency, etc.? And if so, how did you overcome these when mapping and harmonizing these data sources?
I can read as two questions. So regarding the issues, for example, for completeness, consistency, so we had some limitations which were associated with the limitation of routine data. So as you know, routine data are not primarily collected for research, so there are always kind of issues could happen for health data. But the way we did harmonization, so from the beginning, we documented everything, all the rules implemented in each TRE, the method that we use in each TRE, and we had regular meeting between researchers and clinicians in terms of making sure that variables are clearly defined when defining new phenotypes. Clinicians and other experts were involved. We also use descriptive analysis and data visualization to compare initial results and also to visualize the process used in each TRE so that everything would be clear and transparent, and we can check that if there's any issue, we can address them properly.
Can I also add a few points on that? As Hoda mentioned, to add to the preparedness on the raw data level, what we had to do very early in the pandemic, where the daily extract of data started flowing into the SAIL. For researchers, we basically built a quality check algorithm that we haven't covered it in the harmonization work, but that quality check was producing live reports of each daily data that was coming into the SAIL, and then we could see, and we had to, for that, one solution that we developed was to develop a measure against the data set itself. So we were counting the number of rows coming in on a daily basis, and it was the next day data was compared to the previous measure of days because of, for example, over the weekends we could see the drop, so the algorithm wouldn't miss those natural gaps. And so the very supportive SAIL team also contributed greatly in addressing all of the points that we spot, and to going back to the data providers and all of the resources required for this.
Thank you both. Neil Postlethwaite has made a comment. I think he's had to drop off today's webinar, but he was saying that it would be great to signpost, just slid off my screen. It would be great to signpost some of the code assets that have been developed from the Innovation Gateway for community reuse. Maybe I'll just quickly answer this one and then you're welcome to add, but just to let the audience know, all of the code, the phenotypes, the protocols, everything that is derived from the analyses that goes on for each of the projects that have been spoken about today as part of the CVD-COVID-UK COVID Impact Consortium. All of those are made available in repositories in our GitHub organization, and I'll post the link to that in the chat now. And those can also be accessed via the papers and links from those papers on the Innovation Gateway. So hopefully that covers Neil's point, and I can touch base with him offline about that. Hoda, Fatemeh, anything to add on that? But are there any links or things via the SAIL Databank as well?
No, I think you covered really well. So all the stuff in SAIL, so there needs to be access through the consortium, so they're not publicly available, as you know. Okay. But yeah, as you said, so everything that, so following completion of each project, we make available all the codes in BHF Data Science GitHub repository, and also all the phenotypes are added to the HDR-UK phenotype library as well. Yeah.
Great. And there's another question from Steffi here. So are there any projects looking at how we could utilize these data to inform health policy decision making?
That's a challenging question, but I can cover a few aspects of it in terms of the drugs. I'm working with colleagues at MRC Biostatistics units who are very much focused on the trial design and trial data. So I think the contribution of specifically drug dispensing data into health technology assessments, there is a space to make sure that the weights assigned to predict the long-term effect of the trial data comes from the observed survival in the population, and through the data that we hold for the population, this is possible. But yeah, I'm happy to explore that, Steffi, further, because that might be something that I'm blinded to due to my focus on the population data only. So yeah.
Okay, great. And there's another question here, or series of questions or points from Callum McDonald, who's a senior research software engineer here at HDR UK. So he's obviously commending you on your presentation and the work that you've done. And it says he's been working with EVE2 and NCS in different TREs on work to harmonise COVID serology data into the OMOP common data model. And he says, should we be doing more to share the analysis scripts that work with the common data model data? And can these be shared across all 4 nations, TREs, and in theory allow us to get analysis ready results rapidly for policy making, and whether we could do more at HDR UK via the gateway to do that? So there's a lot to digest there.
Yeah.
Which one of you wants to take that first?
It would be great if we can share all these scripts, and for example, if we can have some kind of template for the codes used for analysis or data derivation. But I think I'm not in a position to say if we can use HDR UK gateway. So, but you're more than welcome to.
Thanks, Callum. Like, great point. And I can see where the enthusiasm comes from, because I feel that as well when working in these 3 nation collaborations, and sometimes we are bound to talk over the code because we can't share the screens of the TRE, or we can't overlook the screen. So the code sharing is very important. However, I think I put in my last slide that the limitation at the moment comes from having the live knowledge share. So the codes we share on the GitHub accounts is a single deposit of the pipeline, the final pipeline. But I think some of the issues we track on GitHub issues, GitLab collaborations, you probably are aware of, like open source collaborations are happening within the TRE, and that is at the moment lost. So if we can kind of capture that in a way through the gateway, that would be a fantastic facilitation of knowledge share across these projects. And yeah, happy to talk more about ways to achieve that.
So Callum, and for our audience, just to make you aware, so the BHF Data Science Centre has recently become one of the Eden data partners who are working on creating OMOPed versions of the datasets, or some of the datasets that we're using within the English trusted research environment. So we're currently working to OMOP the primary care dataset, the version that we have, the GDPPR dataset, deaths, HES APC, so hospital admitted patient records, and also the NICOR National Heart Failure Audits dataset. So we're working on those at the moment, and maybe if the serology data is another dataset of interest, maybe we can discuss that offline, Callum. Just seeing if there are any other points. So Anthony has another question. So it's another question related to OMOPing datasets and getting them into the common data model. And Anthony is saying, do you think it's feasible or appropriate for NHS trusts across the UK to invest in convert their datasets into this common data model? And if so, what is your advice for feasibility studies, funding support, and convincing colleagues that it's needed?
Thanks, Anthony. It's, yeah, convincing colleague that it is needed is hard, because the research is happening now without OMOPing. So I think for convincing the community that we really need OMOP on top of the current layers is quite a challenge. However, OMOP will enable us to really go towards multi-TRE analysis, and will probably aid us in containerizing the codes and shipping them over, and the containerized code will run against the OMOP version of the data in Wales, England, Scotland, Northern Ireland, at least at the UK space. So I think that there is definitely benefits, but how to convince, I don't know.
It's a challenge. Okay, we're going to take one more question from Spencer Keane. So Spencer says, are there issues with losing information when harmonizing across TREs? For example, if one TRE has a variable with 6 categories and another TRE has the same variable with 4 categories, then the harmonized variable would have to have less than or equal to 4 categories. Is that correct?
Yeah, so I wouldn't say losing information. So it's all about harmonizing variables based on the strengths and limitation of TREs. So another consideration is regarding, for example, the disclosure control process. So yeah, as I said, I wouldn't say losing, because we need to harmonize the values of the variables as well, considering, for example, availability of data sources and these kind of, for example, categorization that Spencer mentioned. And for the disclosure control process, we might have some issue regarding small numbers. That's what we have had so far, for example, for rare events. In those cases, we probably need to group outcomes at a higher level.
So I'm coming at like a user of the harmonization table, a harmonized table that Hoda developed. Spencer, I can understand where you're coming from. Basically, I needed the same thing. I needed to tweak one of the definitions of a phenotype that was already existing. And what benefited in me using Hoda's algorithm were those layers. So Hoda creates layers in which some of the tables exist as master tables. So I could travel between the layers, and that was a really nice feature of the harmonization algorithm, because while those existing comorbidities in the final tables gives you the definition, for example, for categorization when matched to the definition of England TRE. We needed, and we are still exploring with the ongoing work on the dispensing data, we needed to change, and going through the reviews, change definitions of certain disease indications or variables. So what I did, I traveled back a layer to the master table where Hoda basically preserved all the existing records from the source data, and in a nice tidy format. So you kind of have still some luxury of the benefit of the harmonization process, but you can also now look back in periods, change definitions, and benefit from that. I hope that answers your questions.
We're almost out of time, but just one last quick question for Hoda. Maybe if I could give you 30 seconds to answer this one. So how can you improve or extend this harmonization method?
Yeah, so there are a couple of opportunities to improve or extend this approach. One is obviously to use more data sources in first layer. Another one is to develop new RRDS research-ready version of some data sources. For example, it would be really great if we can have a research-ready version of the lab result, which is a massive data which needs a lot of cleaning processes. We can also add further harmonized phenotypes to third layer. And as I mentioned before, another opportunity is possibly to develop some template for code templates for doing analysis using these harmonized variables.
Great, thanks for that, Hoda, and for keeping to time. So I'd like to say a huge thanks once again to Hoda and Fatemeh for presenting today, and to all of you for attending. And just to let you know that the next webinar will be held on the 19th of July, and registration details will follow in due course. Thank you very much.
Thank you.
Thank you.